Thank you for listening to the latest episode of Little Eyes, Big Topics. In this episode, listen as Dr. Simon Fung discusses the risk factors, diagnosis, and treatment of pediatric keratoconus.
Welcome, listeners, to the Little Eyes, Big Topics APOS podcast. On behalf of the APOS Digital Education Committee, I am Dr. Sruti Rachapudi, a PGY1 ophthalmology resident at Illinois Eye and Ear Infirmary, otherwise known as the University of Illinois Chicago. Today, I have the pleasure of speaking with Dr. Simon Fung. Dr. Fung is an associate professor at UCSF, and he's an expert in pediatric cornea and external eye disease, with 2 fellowships in both pediatric cornea and external disease and refractive surgery. So welcome, Dr. Fung. We are so happy to have you today on the podcast, and we are going to be talking about keratoconus.
Well, thank you so much for having me today.
Of course. So to start, would you tell us a little bit about yourself and what made you interested in dedicating pediatric cornea and external eye disease and anterior segment as a big part of your ophthalmology practice?
Sure. So, hello everyone. This is Simon Fung. So, although initially I come from Hong Kong, my journey in medicine has taken me across many different countries. So, it all began at the University of Oxford, where I completed my medical training. And during my studies, I developed an interest in ophthalmology, particularly the impact that vision has on overall health and quality of life. And this passion drove me to pursue an ophthalmology residency and then a corneal fellowship at Moorfields Eye Hospital in London. And it's during that time that I remember treating a young patient who had been struggling with an inherited corneal condition that significantly impaired her vision. And this condition not only affected her ability to see, but also her confidence and performance in school. And it's only through a series of treatments and eventually a corneal transplant that we were able to partially restore her vision. And even though it was only a partial restoration, it was enough to bring joy and relief to her face, as well as her family, who you can really tell that it made a huge difference. And it's really this experience that changed my thinking about how profound an impact we can make in restoring sight on a child's life and solidify my commitment to specializing in pediatric cornea and external disease. So in January 2016, I joined the Hospital for Sick Children in Toronto, and I was the second fellow in the Pediatric Cornea and External Disease program. And this experience was really transformative, and it reaffirmed my passion and dedication to this specialty. And after completing my fellowship in July 17, I joined the faculty at Stein Eye Institute at UCLA, and recently I moved to UCSF as an associate professor.
Thank you, Dr. Fung, for sharing a little bit about your background with us. So what exactly is keratoconus?
So keratoconus is a progressive eye disorder that can cause the cornea, the front part of the eye, to thin and bulge into a cone-like shape. The condition typically affects both eyes, and even though it's not often symmetrically, it can have a profound effect on the visual acuity. While the exact cause of keratoconus is not fully understood, it's thought to result from a combination of genetic and environmental factors. Now, the risk factors of keratoconus include a family history of the condition and also parental consanguinity, indicating that there may be a hereditary component. And in fact, there are some genes that has been identified to be associated with keratoconus now, but we don't have a causative gene identified so far. The exact inheritance pattern is still unclear, with both autosomal dominant and recessive patterns being shown and proposed. So, for example, in 2023, there's a study looking at 24 Spanish families with pediatric keratoconus, and they use whole exome sequencing to look at the candidate genes involved in the condition. And then they identified there were many genes involved in the structure, the function, the cell adhesion, development, and repair pathway of the cornea, but none of them were the single causative gene. So there are many possible associations that we don't know just yet. In terms of the environmental factors, that's quite interesting because there are a number of significant contributors. Eye rubbing, especially during childhood and teenage years, is a major risk factor. and chronic eye rubbing can lead to ocular surface inflammation and other cellular changes that contribute to the disorder. Other environmental factors linked to keratoconus include allergies, floppy eyelid syndrome, contact lens wear, and thyroid hormone imbalances. Now, keratoconus is more prevalent in certain ethnic groups, suggesting that maybe both, again, genetic predisposition and also specific environmental influences are in play. And there's a strong association between keratoconus and also dry eye disease found in over 80%. This link may be because of the different mechanisms, including the inflammatory and immune responses. So I think, in summary, keratoconus is more complex than we think, and is a condition influenced by genetic predispositions, environmental factors like eye rubbing and hormonal changes, and all these factors together lead to corneal thinning, irregular astigmatism, and eventually visual impairment.
Thank you for sharing that. I certainly agree that environmental factors such as eye rubbing, especially during childhood and teenage years, can be a risk factor. Can you share more clinical pearls about the differences in pediatric keratoconus versus adult onset keratoconus?
Yeah, when we discuss the differences between pediatric and adult onset keratoconus, there's several points come to mind. So, first of all, keratoconus tends to be more common in pediatric populations in terms of prevalences. So, for example, there's a study recently came out from Chicago at a pediatric vision clinic, and they reported a prevalence of 1 in 334 patients for keratoconus and 1 in 670 for keratoconus suspects among children aged 3 to 18 years of age. And similarly, a study from Egypt found that a prevalence of 4.8% among children with significant astigmatism, which is roughly about 1 in 220 in overall. Now, put it in contrast, the prevalence in adults generally ranges from 1 in 375 to 1 in 2,000 individuals per year. So it seems like it's more common in children. However, it's important to note that currently we don't really have an age-adjusted diagnostic nomograms on any of our corneal diagnostic systems. So some of these figures may have been overestimated, with the true prevalence of the condition somewhat lower than the one that we have seen in these studies. Another difference is that pediatric keratoconus typically manifests in early teens, with the diagnosis sometimes occurring as early as 7 years old, the one that I've seen. And also, there's a higher prevalence in males, with 64% of pediatric cases occurring in boys. Common clinical associations will include allergic conjunctivitis and also eye rubbing behaviors, both of which we've talked about contribute to the development of the disease. But also in the pediatric cases, I found them to be really factors to accelerate the progression seen in children. Now, pediatric cases often present at more advanced stages compared to adults. For example, a study back in 2012 by a French group in Bordeaux found that 28% of children would present with stage 4 keratoconus, the sort of the most advanced stage at diagnosis, when compared to their own adult patients, only 8% of the patients did. And additionally, more children exhibited clinical signs of keratoconus at the slit lamp than adult patients. So this earlier and more severe presentation in children highlights the need for early screening and also timely intervention to catch the disease before it causes significant corneal damage and vision problems. And clinically, it's crucial to keep an eye out for subtle signs in young patients and act quickly to manage the condition effectively. Now, before I move on to the next one, I think we should talk about a landmark study by Nikuchasis and Fahad Havezi in 2012, who many of us have cited as the reason why we want to intervene so quickly. Back in 2012, this Swiss group revealed that there's an astonishing 88% of children with the diagnosis of keratoconus showing disease progression. And their research really indicated that the progression rate in pediatric keratoconus could be significantly faster, up to 3 times more rapid than in adults. The interesting thing is that the same French study we mentioned earlier found that over a 2-year period after the diagnosis of keratoconus, the frequency of keratoconus progression did not significantly differ between children and adults. Still, for those children who did progress, the rate was much faster, with the increase in the maximum keratometry value, so how steep the cornea is, changing nearly 4 times more in children compared to adults in the same time period. So in summary, I think pediatric keratoconus require very close monitoring and early intervention due to its higher prevalence, the more rapid progression, and a tendency to present at more advanced stages than adult patients. And it's important to recognize these differences in managing the condition between the children and adults and preventing severe visual impairment in younger patients.
In children, of course, we learned that keratoconus is not only more frequent, but can progress at a faster rate compared to adults. I was just wondering, could you talk about some of the challenges that come with the necessity of screening children at such a young age, especially if some of them are nonverbal or perhaps are having academic challenges in school? What does that conversation look like in detecting those early presenting symptoms in these types of children?
I think that's a great question because we know that keratoconus is associated with trisomy 21, with patients may be affected by different degrees of developmental delay. I think when it comes to screening in these children, first of all, history taking is still important. And really, it's going back to visual function reported by the families. If there were suspicion that visual function is reduced, one should start to have a lookout for possible changes. We did mention that the age of presentation typically would be after 7 years and typically during the early teenage years. So most of the time, we do not have to worry about language issues. On the other hand, in those who are developmental delay, they may not be possible to express what they're having issues with. In those children, I find that screening comes in sort of 2 ways. One is in clinic, and one is with our diagnostic devices. And I specifically listed those 2 because, number one, they're not the same. And number 2, we may have been overly reliant on the latter, which is the diagnostic devices, and forgot about clinical skills, using those instead to screen these children. So in my clinic, I oftentimes would start with examination with retinoscopy. And apart from trying to look for the refractive error, the appearance of the retinoscopy Myers really tells a big story whether the cornea is regular or irregular. In fact, there has been a study in recent years that looked at the use of retinoscopy as a screening device and found that it's been very successful in detecting early keratoconus, purely from the appearance of the retinoscopy Myers. In children who could actually tolerate the corneal imaging devices and the investigations, then a corneal topography or a corneal tomography will really be the center of care in diagnosing children with keratoconus. I think I'll just pause here and talk about a little bit about screening and how we should really think about how it could be done. When it comes to screening, I think we should think a little bit about what screening really means. According to the World Health Organization, screening is supposed to have a large prevalence of disease, an effective way and an accurate way to diagnose the disease, and also an intervention that we can bring about. I think with some of the facts about the keratoconus that we don't know about yet, I'm not sure we can have a population screening of keratoconus at this stage. However, I do think that we can definitely raise the awareness and be cognizant about how keratoconus could present in the pediatric clinic and look up for ways to identify these children earlier.
So, this holistic approach of not only involving the diagnostics of keratoconus, but also these types of conversations with both the patients and parents is extremely important. I would love to know more about what this discussion process looks like with parents and patients regarding the treatment of keratoconus. So can you talk a little bit more about the main non-surgical and surgical treatments for these patients?
So when dealing with pediatric keratoconus, we have three treatment goals. Number one is to protect vision. Number two is to halt disease progression. And number three is to preserve corneal clarity to avoid the need for a corneal transplant. And I think it's very important to list these three goals with the parents right from the start so that they understand what is involved in the treatment of keratoconus. Now, the decision making obviously involves a discussion with not just the patient and the parents, but also with other ophthalmologists. It's not uncommon that pediatric keratoconus is co-managed between a pediatric ophthalmologist and a corneal specialist. And other factors that would involve in the decision making would be the age of onset, the progression rate, the treatment combinations, and patient compliance, as well as the need for regular monitoring. Treatment options in the past were only limited to just contact lenses and corneal transplant, and that was the standard of care for many, many, many decades. But they have now greatly expanded. The treatment now, I would say, is divided between stabilizing the disease and improving vision. And they're very different. So let's look at those two separately. For stabilizing the condition, corneal cross-linking is the number one treatment and is the only treatment that is shown to be able to stabilize the condition. Corneal cross-linking strengthens the cornea and prevents further thinning or steepening, which is particularly vital during developmental years because we know that children progress at a faster rate. Now, there are different modes or protocols of corneal cross-linking. The FDA-approved version in the United States is called the Dresden Protocol, also known as the conventional protocol. This protocol involves removing the surface layer of the cornea, the corneal epithelium. Then we put in the special drops called the riboflavin for 30 minutes to soak the cornea to make sure that it's saturated. And then we apply ultraviolet light to activate the riboflavin and then create the photochemical reaction. The procedure is recommended when we detect rapid progression, and it's been shown to have a very good safety track record and also effectiveness in both adults and children. It's important to note here is that the indication for cross-linking, according to the FDA, is progression, not at the point of diagnosis. So a child with just a diagnosis of a keratoconus, but without a demonstrated progression, will not be indicated to have cross-linking according to the FDA ruling. So for vision improvement, there are a number of options that we can choose from. Rigid gas permeable contact lenses are still important, and they are pivotal in correcting the irregular corneal shape and improving visual acuity. If the standard contact lenses are not suitable, nowadays we typically use the larger sizes, mini scleral or even the full-size scleral lenses, which can fold over the cornea and reducing any contact over the cornea. And they could be very beneficial and very good compliance rate, even in children. There are people who talk about using something called intracorneal ring segments for the treatment of keratoconus. So ring segments are either synthetic or human corneal tissue material that were reshaped into like a ring shape. They can be placed within the corneal stroma, reshaping the cornea and helping the refraction to be better and aiding, for example, like the fit of the contact lenses. Now, I have to say that the use of intracorneal ring segments have been used in children, but hasn't been extensively studied, and it's not something that I routinely offer to children. In some selected cases, topography-guided photorefractive keratectomy, or PRK, could be used alongside cross-linking to not only correct the corneal shape and the refractive errors, but also to stop the disease progression. Now, this has primarily studied in adults only. I haven't seen that done in children, and it's mostly done outside the United States. So whether this could be something we can use in children is something for future investigation. So lastly, after all these treatments for both vision and also for disease stabilization, if all these treatments fail, then corneal transplantation is necessary. Now, traditionally, we use a full thickness transplant or a penetrating keratoplasty, and this is still an option for severe cases where there's a lot of corneal scarring or the treatment is not possible to do anything else. But alternatively, we are more increasingly now use a layered approach, like what we call a deep anterior lamellar keratoplasty. And as I mentioned before, this is a layered approach, which means that we tease off layers by layer of the cornea until we reach the very deep, ideally just before the descemet membrane. And we prefer this approach, even though it sounds much more time-consuming, because this type of keratoplasty will have a much lower risk of rejection and can be considered even in children. Now, however, even after successful corneal transplant, glasses or contact lenses are often still required for clear vision. So oftentimes I tell the parents that corneal transplant is not the panacea, it's not the single treatment that you want in keratoconus, because you're not shaking away the need for glasses or contact lenses. So it only applies when the condition is very severe. So managing pediatric keratoconus requires a collaborative approach and to balance the treatment options for disease stabilization and vision enhancement, from corneal cross-linking to contact lenses and surgical interventions. The goal is simple, is to preserve vision and prevent disease progression, and with transplant as the last resort.
Thank you for explaining that wide variety of treatment options available to patients with keratoconus. This is very helpful for resident trainees like myself, especially because we have a lot of medical students and residents that are avid listeners of this APOS Little Eyes Big Topics podcast. Is there a particular clinical story that comes to mind of a pediatric patient with keratoconus undergoing treatment that you would like to share with us that you think would be beneficial for our learning?
Obviously, with HIPAA compliant, we got to make sure that the identity is not revealed. So I would say that once upon a time, which means it's the way to encrypt the names, I saw a teenager who is really passionate about soccer, or we say football in Europe, and spending time outdoors with friends. However, he faced challenges when his vision started causing issues, especially during soccer matches. He told his parents, and his parents took him to an eye checkup and eventually came to my clinic. So following examination and also the corneal diagnostic imaging, he was found to have keratoconus, particularly in the right eye. It was a challenge for him and his family because he actually wanted to be a professional athlete. So after a brief monitoring period, it also became evident that his keratoconus wasn't just diagnosed, but also was progressive and required intervention. He had his first corneal cross-linking procedure in his right eye a few months after the diagnosis, so maybe about a month after the discovery of the condition being progressive. Being young and understandably very anxious, this procedure was performed under general anesthesia, something that we can do for children and also for those who are developmental delay. Usually in adults, this would be done under topical anesthesia. Now, about a week after the procedure, he went back to school and he can resume normal activities. For the first week, he did say that, yeah, it was a little bit blurry. And certainly the first 2-3 days, it was not comfortable. But a week later on, he's back to normal. And over a few years, he attended follow-up appointments. He was closely monitored. And his right eye has been totally stable. He hasn't had any issues. The new issue, however, unfortunately, was actually his left eye became also progressive, even though it was a much slower rate. And because of that, and because we know how successful cross-linking was in his right eye, we probably have him to undergo the second procedure in the left eye. So this time, because he's now much older, late teenage, he was able to undergo the cross-linking procedure under topical anesthesia. So just with numbing eye drops and a small dose of oral sedation. And he tolerated the treatment well, and there were no complications. So at one of the most recent visit, I think roughly about a year after his second treatment, his condition is stable. His vision, actually interestingly, was also improved, which in some cases of cross-linking cases, they can experience improvement in vision. So while he can read 20/40 in the more advanced right eye, he maintained 20/20 vision in the left eye, despite the early keratoconus. And he's going into college and thinking about being in the college team for soccer.
That's wonderful to hear. So, just to wrap up our conversation today, what advice would you give to medical students and ophthalmology residents who want to get involved in research regarding pediatric cornea and external disease?
It's a great question. And I think, first of all, I would say that pediatric cornea and external diseases, this is a niche topic. I think for medical students, residents, or trainees interested in exploring this research in this field, I would definitely recommend seeking out some really experienced mentors in this niche field. There are not many of us out here or out there. So I think it's important to find somebody who is very experienced in this area and then ask the questions. The mentors can offer a lot of guidance, a lot of support, but also helping you to navigate the complexity of the pediatric corneal conditions. Research projects are obviously important, whether it is literature review, data analysis, or hands-on clinical investigation. It's important in gaining that practical experience and also contribute to the advancement of knowledge in this specialized area. It's important to stay updated on the latest developments by going to conferences and networking with your peers. And by immersing yourself in pediatric corneal research, and I think aspiring ophthalmologists and also hopefully aspiring pediatric corneal specialists, you can really make some meaningful changes and contribution to the field. And in the process, will improve the outcomes for young patients with corneal diseases.
Wonderful. Thank you, Dr. Fung, for talking with me today about keratoconus and pediatric cornea disease and pediatric ophthalmology. Do you have any social media platforms you wish to share with our audience so that they can continue to follow your body of work?
Absolutely. So my handle is very simple. It's Dr. Simon Fung in one word. And I can be found on LinkedIn, anything on Meta, and also on X.
Wonderful. And don't forget to also follow APOS at APOSI on Instagram. On behalf of the APOS Digital Education Committee, thank you so much, Dr. Fung.
Thank you so much for having me again.